promoter region, exons, and introns are present on these chromosomes tightly coiled as DNA. So a gene contains a promoter region and intron and exon. This is just an introduction about the genes. I'm not getting into the gene aspect of it. Now, coming to the chromosomes, what happens is mitosis and meiosis play an important role in our cell division. So mitosis is a two-cell state, diploid cell giving two daughter diploid cells, wherein the number of chromosomes is fixed. A two diploid cell is divided and giving rise to diploid cells only. But whereas in meiosis, the reduction division occurs. So set diploid chromosomes are divided and haploid gametes are formed. So this is the difference between mitosis and meiosis. Now, the same is represented with spermatogenesis and oogenesis, like I've discussed earlier. All the somatic cells have diploid chromosomes except the germ cells. Germ cells are sperms and eggs where they only have haploid number. So again, I repeat, the haploid numbers, haploid sperm and haploid egg fuses to form a diploid gamete, diploid embryo, sorry. So why and when are these tests done? These genetic tests are done to identify the causes for subfertility. They are done at different stages, while premarital, preconception, post miscarriages. At all these phases, these tests come into role. And the genetic tests are also done not only to check for chromosome rearrangements or numerical abnormalities. It is also done to check at the gene level during pre-implantation testing or prenatal testing. So there are different levels and types of genetic testing. So yeah, what are the common causes of subfertility in males? It is all of us know, Klinefelter. There are certain chromosome syndromes which are the cause for subfertility. Klinefelter, Jacob, and chromosome translocations, Y chromosome microdeletions, some trisomies and epigenetic factors are the commonest causes. In females, Turner syndromes, translocations, Swyer syndrome, and POF are some chromosomal regions with which the subfertility is seen. So this is what a cytogenetics team does. So we get a sample, be it a blood sample or a bone marrow sample. There are two types of workflows which you see here. So take the blood sample, culture the blood, and arrest the cells. If it is in peripheral blood, yes, the culturing method is different for bone marrow cells and peripheral blood cells. So we arrest the chromosomes at their most condensed phase. So we want the chromosomes at metaphase. So we arrest them, fix them, and put them onto a slide, stain them, and under microscope, we evaluate the chromosomes. We check the number and structure of the chromosomes. This is how it looks like after the slide is made on low power at 10 power under a microscope. You can see these metaphases. These are called metaphases where the chromosomes are spread across. That group is a metaphase where it has 46 chromosomes in the condensed form. Then onto your right is the high power under 100x. This is the GTG banded karyotype where the bands are seen on the chromosomes under 100x. So we follow International Society of Chromosome Nomenclature, ISCN. Now recently it is ISCN 2024. According to ISCN 2024, we arrange the chromosomes and report the karyotypes. So this is onto the left is a normal karyotype with 22 sets of autosomes, that means the common ones, and the last pair, 23rd pair, is XY, which is allosomes. Allosomes means the sex chromosomes. Onto the right is the ideogram, which represents the bands. So based on that is the reference with which we arrange the chromosomes. Now, coming to the numerical abnormality, there are two types of chromosome abnormalities. One is numerical and the other one is structural. So numerical abnormalities means a gain or loss of one entire chromosome, which is commonly seen. We have discussed about common factors like Klinefelter, Turner syndromes causing infertility. So these syndromes are caused because of loss or gain of one entire chromosome. Now, how does this happen? During the meiotic non-disjunction, during the meiotic division, due to the non-disjunction, there can be a gain or loss of chromosomes, which results in the aneuploid fetuses. Aneuploidy is, euploid means they are diploid. Two sets are completely present. Aneuploid is gain or loss. Now, coming to the first type, Klinefelter syndrome, it is caused because of an additional X chromosome in males. 47XXY is a classic Klinefelter syndrome karyotype looks like. So there's an additional X chromosome. On to the other side, you can see there is one more chromosome. If you see the karyotype representation, it is 48XXY. It is a variant Klinefelter syndrome. The clinical presentation would be more or less similar, but there is an additional X chromosome. Instead of 47, it is 48. So all these are sporadic. The numerical abnormalities are mostly sporadic, except in the case of the Robertsonian translocations, which I'll come in a while. So there's extreme heterogeneity in the clinical presentation of Klinefelter syndrome. So gynecomastia, sparse facial and body hair, small testes, and inability to produce sperms will be the classic presentation. So 90% of the cases have this classic Klinefelter presentation, but some around 10% cases have mosaic pattern. Also, the variant pattern of Klinefelter is seen. So patients with Klinefelter syndrome needs to be followed throughout life to have their testosterone treated, and also they may need some psychiatric consultation. So based on the diagnosis, the treatment and management options will differ. So reproductive evaluation will be done after the karyotype based on the hormone evaluation. The next condition is Turner syndrome. Turner syndrome, the most common numerical aberration seen, which it is also referred to as congenital ovarian hyperplasia syndrome, which is the most common sex chromosome abnormalities which is found in females. So it is seen in about 1 in 2000 to 2500 live births. So it is usually presented as primary amenorrhea or delayed puberty. And most of these women with the Turner syndrome are infertile, so IVF would be the option for them. There are also variants in Turner syndrome like iso-X chromosome, where the complete P arm of the X chromosome is missing, only the two Q arms are present, that is iso-X. That is one form of variant. Turner syndrome, also ring chromosome, XP or Q deletions are seen. See, these are the karyotypes which represent the classic 45X Turner syndrome, where there's no other X chromosome, and the other two are iso-X, where only Q arms are duplicated and seen on the karyotype, and the other one is the deletion X chromosome. All these are the variants of Turner syndrome. The other numerical abnormality syndrome is Jacob syndrome, which is also rare. It is having an extra Y chromosome from the father. This is again because of the meiotic non-disjunction. However, here the extra chromosome is Y chromosome. So majority of them go undiagnosed due to the mild presentation, but they seem to have increased risk for certain comorbid conditions like asthma, seizure disorders, and ASD, autism spectrum disorder, or learning disabilities. So the incidence is 1 in 1000 males, and men with subfertility need evaluation. Maybe they need assisted reproductive techniques to have fertility. Here, the karyotype shows there is one additional Y chromosome, 47XYY. So Swyer syndrome is again pure gonadal dysgenesis, which is seen in females. But the karyotype, when we do a karyotype of a female, it will be 46X. With streaky gonads that ought to be removed because of the malignancy potential. And the incidence is very rare, 1 in 80,000. So the treatment is again based on the hormonal presentation, and the gynec and the endocrinologist takes care of it. So this is how a karyotype of Swyer syndrome individual looks like. Absolute normal male karyotype, but seen in a female. This is Swyer syndrome. And this is Dila-Chapelli syndrome. This is the opposite to what we see in this syndrome. So it has 46XX karyotype in males. It is not as rare as Jacob syndrome. It is 1 in 20,000, and this syndrome accounts for the 2% of male infertility cases. Most of them are, like we've discussed, sporadic. And in these cases, further genetic evaluation is mandatory, because some males with 46XX karyotype have SRY region intact and AZF region due to some translocation. So further evaluation is very important in such cases. This is how a karyotype looks like in Dila-Chapelle syndrome, where it is again a classic female karyotype seen in males. So the treatment again is based on the hormone evaluation, and multidisciplinary approach is required to treat these patients. So without karyotype, it would be very difficult, because going forward with assisted reproductive techniques without chromosomal analysis would subject the family to so much of financial and psychological pressure. So coming to the mechanism of the structural abnormalities, the name itself says it is either a deletion of small portion or duplication or a reciprocal translocation. In females or males with subfertility, the most common presentation would be a reciprocal translocation. That means there is no loss or gain of chromosome material, and that's the reason the couple will be normal phenotypically. However, there will be a rearrangement in the chromosomes, which results in multiple abortions or congenital, or giving birth to individuals with children with congenital abnormalities. The other one is Robertsonian translocation, which is a translocation specific to the acrocentric chromosomes, which are DG associated chromosomes. Also, inversions are seen. Inversion is just an inversion across the centromere, is known as pericentric inversion, and if it is within the arms, it is known as paracentric inversion or ring chromosome. All these are the structural abnormalities, types of structural abnormalities seen in subfertile couples. So reciprocal translocations, if it is a reciprocal translocation in any of the couple, then they have around 50% of risk for having abnormal gametes, resulting in either an abortion or a birth to a child with congenital malformation. So these are the possible outcomes. So it is essential to evaluate both the partners before proceeding with any of the fertility options. Also, if they have a strong history of miscarriages, if they have strong history of recurrent miscarriages or bad obstetric history, this is the first line of testing which has to be considered. So these are some of the examples. In the first karyotype, you can see there's a translocation between chromosome 1 and 6. So this female has a balanced translocation. She's absolutely normal phenotypically, but her chromosomes are like this. And when she gives these chromosomes, only one set from her are going to the child and the other will come from the father. Now, based on which chromosome is coming to the embryo, the fate of the embryo is dependent. So if it is a balanced one like the mother, there's again a chance of the fetus being a carrier. It can still be a completely normal with the two normal copies. All these are fine. This is around this accounts up to 50%. But the other 50% is where they are unbalanced gametes, where the broken part and the normal part is coming up. Then the aneuploidies are seen and the abortions happen. Based on which chromosome, the intensity differs, because the long chromosomes have so many genes and they usually end up in early abortions. On the other side, you can see a translocation of chromosome 7 and 13 in a female. This is another balanced translocation. Coming to the Robertsonian translocations, like I've discussed, it results only between the acrocentric chromosomes, the short ones with a very reduced PR, and there is high prevalence of these, 1 in 1,000 newborns. So the like other reciprocal translocations, for Robertsonian translocations also, there is a risk of recurrent miscarriages. And also the most common syndromes which are seen because of Robertsonian translocations are Down syndrome, Patau syndrome. So here is a karyotype of an individual. This is a normal male with a Robertsonian translocation. If you see the karyotype nomenclature, it says only 45. It should technically be 46. But this individual, despite having 45 chromosomes, is normal because the other 21 is sitting on the chromosome 14. If you see on this, here the chromosome on the chromosome 14, the chromosome 21 is sitting, and this is called a derivative chromosome Robertsonian translocation. Now, this individual is fine, but when he gives this Robertsonian translocated chromosome, then it ends up in monosomy or trisomy in the fetuses in the next generation. Also, the other types of changes include heteromorphic variants, which are very commonly seen, and according to the new nomenclature, the cytogeneticists are not supposed to report the variants in the main report, but should just give as an additional comment where the genetic counselor takes care of the counseling part of it, whether it means something to the couple or not. So there are, because the clinical significance is not very well understood. So some studies say yes, pericentric 9 inversions and Y inversions cause subfertility and some syndromes, but it is not completely proven. So, taking into consideration the family history, personal history, obstetric history, this heteromorphic variant significance may vary. That's the reason we definitely mentioned about genetic counseling in such cases. So for some conditions like YQH minus, which is another heteromorphic variant, we recommend for Y chromosome microdeletions where we check for actual YCMD deletions. If we are saying that it is a variant, it should not technically have any YCMD deletions, YCMD. But if it is there, then it is not a heteromorphic variant. So we correlate that way. So these are some of the heteromorphic chromosome variants: 21 PS plus, 9 QH minus, 15 PS plus. These are the images of karyotypes which have chromosome heteromorphic variants. And inversions. This is another important heteromorphic variant again, like I've just discussed. Paracentric within the arm, pericentric across the centromere. So here again, it is many studies suggest that inversion carriers may produce abnormal gametes, so leading to partial deletion or duplication of the embryonic chromosome material, which end up in spontaneous abortions of fetuses with multiple anomalies or birth of a malformed child. So genetic counseling remains very challenging in these cases and important as well. So these are some of the inversion karyotypes: Y inversion, chromosome 9 inversion. Yeah, coming to the last part of it. So with all these results, not only the cytogenetic results, all the molecular genetic testings need proper genetic counseling, and it is the delivery of a professional advice concerning the magnitude and the implications of the available tests, and also the alternatives to deal with the risk of recurrence and hereditary aspect of it within a family or an ethnic group. So it plays an important role in helping the couples understand which test to be taken, what are the possible outcomes, and what does it mean to them and their family to make informed choices and be successful in their fertility journey. So I end my session with that. I'm happy to take any questions. Thank you so much.
Thank you, Dr. Pavani, for a wonderful presentation.
Thank you, ma'am.
Forum is open for questions, please.
If there are any questions, ma'am, in the chat also, no, we don't see any.
If no questions, then
should we call it
we'll close the session. Thank you.
Yes, ma'am. Thank you, ma'am. Bye.